Hey everyone, and welcome to the Deep Dive. We're diving into all the need-to-know info for the MCCQE, so get ready.
You know it.
I'm Donna.
And I'm Harvey.
And we've been in the MCCQE world for what feels like forever.
Forever. Yeah.
You've pretty much seen it all.
And done it all.
And we're so excited to be your study buddies.
Yeah.
We're breaking down all those big concepts.
The important ones.
That you'll need to crush this exam.
Absolutely.
So if you're feeling a little overwhelmed,
like totally,
don't worry.
We gotcha.
We'll be using awesome resources like Stat Pearls.
Gold standard.
To make sure you're getting the most up-to-date info.
For sure.
But before we jump in,
yeah,
quick disclaimer.
Always.
This is not medical advice.
Right.
Always consult with a qualified healthcare provider.
Your doctor.
If you have any health concerns.
Absolutely.
Okay, so with that out of the way.
Let's do it.
Let's dive into our first topic, atelectasis.
Atelectasis.
A respiratory issue that's way more common than you might think.
Oh, yeah. Way more common.
In fact, did you know that almost 90% of patients under general anesthesia
90%
experience some degree of atelectasis?
It's crazy.
That's wild. So what exactly is atelectasis?
Well, the term itself comes from Greek words meaning incomplete expansion.
Okay.
So basically, it's when a part of your lung collapses and it prevents air from reaching those little air sacs.
Those alveoli.
Yeah, alveoli, exactly.
So no air in the alveoli means no gas exchange.
And that's a problem.
Yeah, that sounds like a problem.
It is.
So tell me more about the different types of atelectasis.
Okay, so there are two main types. Obstructive and non-obstructive.
Obstructive versus non-obstructive.
Yeah.
Okay, what's the difference?
So obstructive atelectasis is basically like a roadblock in your airway.
A roadblock.
Yeah, think of a mucus plug or a tumor or even a foreign object.
Oh, wow.
Yeah, anything that blocks the air from getting to those alveoli.
So the alveoli can't inflate.
Exactly, they collapse.
Gotcha. Okay, so that's obstructive.
What about non-obstructive?
Non-obstructive, yeah. What causes that?
So imagine someone pressing down on your lungs from the outside.
Okay.
It could be fluid buildup or a pneumothorax.
The collapsed lung.
Right, or even issues with surfactant.
Surfactant, the stuff that keeps premature babies' lungs from collapsing.
That's the one.
Okay, so if you don't have enough surfactant...
Those alveoli just can't stay inflated.
It makes sense.
Yeah.
You know, I used to think that things like COPD or asthma would make atelectasis more likely.
Oh, I hear that all the time.
But the research actually says otherwise.
Nope, not really.
So what are the real risk factors?
Okay, so immobility is a big one.
Immobility, okay.
So think about patients who've just had surgery.
Or who are bedridden.
Exactly. If you're not moving around, those lungs aren't getting a good workout.
Right.
And atelectasis can sneak in.
Just getting those patients moving after surgery is super important.
Super important.
What else?
Mechanical ventilation is another major risk factor.
Okay.
Especially after cardiac surgery.
So their lungs are kind of on autopilot.
Right. They're not working as hard to breathe.
Which can make them more likely to collapse.
Exactly.
Okay, what else?
Obesity, pregnancy, and even poor pain control.
Wait. Poor pain control. How does that play into it?
If you're in a lot of pain after surgery, are you going to take nice deep breaths?
Probably not.
No way you're going to take shallow breaths.
Which can lead to atelectasis.
You got it.
It all comes back to atelectasis.
It always does.
So let's talk about what's happening in the lungs when someone develops atelectasis.
Okay, so anesthesia plays a big role.
Anesthesia.
Yep, general anesthesia and those muscle relaxants.
The ones they use during surgery.
Exactly. They can really mess with your lung mechanics.
How so?
They change your breathing patterns and reduce your lung volume.
So they make atelectasis more likely?
More likely.
And then if you add in immobility and poor pain control?
It's a recipe for disaster.
Like the perfect storm for atelectasis.
Exactly.
Okay, so why does all this matter for us future doctors?
Because the more we understand about atelectasis,
the better we can prevent it.
Exactly. We can anticipate who's at risk and take steps to prevent those tiny air sacs from collapsing.
So it's all about being proactive.
And informed.
Okay. So let's talk about what to look for if we suspect a patient might have atelectasis.
Okay, so the classic signs are difficulty breathing, rapid breathing, and low oxygen levels.
Difficulty breathing, rapid breathing, and low oxygen.
Yep. But patients might also complain of things like coughing or chest pain.
Especially when they take a deep breath.
Right, and you might even notice a bluish tinge to their skin.
Because they're not getting enough oxygen.
Exactly.
Okay, so what about when we're actually examining the patient?
You might hear decreased breath sounds over the affected area.
Okay.
Percussion can also be helpful.
Tapping on the chest?
Yeah. You might hear a dull sound over the collapsed area.
Interesting.
And you might even hear crackles, which means there's fluid in the airways.
So it's like putting together a puzzle.
Right.
You've got the patient's symptoms, the physical exam findings.
And then you need to confirm the diagnosis.
How do we do that?
Chest x-ray is usually our first step.
The good old chest x-ray.
It can show us those areas of collapsed lung tissue
Sometimes a CT scan is needed,
to get a more detailed picture.
especially if something more complex is going on.
Right.
What about ultrasounds?
Ultrasounds are super helpful in critically ill patients.
The ones who can't move for a CT scan.
Exactly.
Okay, and what about bronchoscopy?
Bronchoscopy lets us look directly into the airways.
With a tiny camera.
Yep. Super useful if we think there's an obstruction we need to remove.
You know, there's this myth that postoperative fever
Yeah.
always means atelectasis.
I hear that all the time.
But I was reading some research,
Uh-huh.
and it seems like that's not really true.
It's a common misconception.
So we need to consider other causes of fever.
Always.
Okay, so let's talk treatment.
Treatment time.
How do we manage atelectasis
The goal is to re-expand that collapsed lung tissue.
and get those alveoli working again?
Exactly.
So how do we do that?
We've got a few tricks up our sleeves.
Okay, I'm listening.
Deep breathing exercises can work wonders.
Deep breathing,
Sounds simple.
but it's effective.
It helps open up those airways and reinflate the collapsed areas.
Okay, and what about incentive spirometry?
Oh, yeah. The game for your lungs.
I love that.
It helps patients take deep breaths, and it gives them visual feedback.
Okay, so what if those simple techniques aren't working?
Then we might need to bring in the big guns.
The big guns. Okay.
Chest physiotherapy can be really helpful.
Clapping on the chest.
Exactly, to loosen up any mucus.
And if there's an obstruction we can't clear.
We might need to do a bronchoscopy.
So bronchoscopy isn't just for diagnosis.
Nope, it's for treatment too.
Interesting. And in some cases,
Some might even need to use positive pressure ventilation.
to help the lungs expand.
Right.
So thinking back to those different types of atelectasis,
Obstructive and non-obstructive.
does the treatment change depending on the cause?
Absolutely.
Right.
So if the atelectasis is caused by a mucus plug,
Okay.
we might use medications to thin the mucus.
Make it easier to cough up.
Exactly.
But if it's caused by a tumor,
Then we need to address the tumor.
through surgery or radiation.
Right.
And if it's caused by fluid buildup,
We'll need to drain that fluid.
so it's all about identifying the root cause.
Yeah. Tailoring the treatment.
Okay, so why is it so crucial to be on top of atelectasis?
Because atelectasis can lead to some serious complications.
Like what?
Pneumonia, respiratory failure,
Longer hospital stays, higher healthcare costs.
and even...
It can even be fatal.
Right. It's important to be upfront about that.
So by being vigilant and intervening early
We can really improve patient outcomes.
and prevent those serious complications.
Absolutely.
So it's not just about treating atelectasis,
Well, it's about preventing it.
and we can't do it alone, right?
It takes a village.
It takes a whole team of healthcare professionals.
Working together.
So tell me, what's the one key takeaway you want our listeners to walk away with today?
Early recognition is key.
Early recognition.
Know the risk factors, be vigilant, and don't hesitate to act quickly.
If you suspect atelectasis.
It could make all the difference.
Okay, future doctors, that's a wrap for part 1 of our deep dive into atelectasis.
We covered a lot.
But before we move on,
Yeah.
I want to leave you with something to think about.
A little brain teaser.
We've been talking about atelectasis in a general sense,
Right.
but how might its presentation and management differ in specific patient populations?
What about kids, the elderly, or people with underlying lung diseases?
That's a great question.
We'll be diving into that
And more.
in part 2.
Stay tuned.
All right, so let's talk about obstructive sleep apnea, or OSA.
OSA, the one where your breathing stops and starts while you sleep.
Yep, that's the one.
It sounds kind of scary.
It can be, and it's more common than you think. Almost 1 billion people worldwide have OSA.
1 billion? Wow, that's a lot of people.
And it's not just about feeling tired. OSA can have serious consequences.
Like what?
Heart problems, mental health issues, even accidents because of daytime sleepiness.
So what causes this breathing problem during sleep?
It all comes down to a blocked airway.
Yeah.
Imagine those soft tissues in the back of your throat relaxing during sleep and obstructing airflow.
So it's like a physical obstruction, kind of like obstructive atelectasis,
Exactly. The airway is compromised.
but for different reasons.
Right. So in OSA, things like obesity, a thick neck, enlarged tonsils, or even certain facial structures
Like a receding chin.
can all contribute to the blockage.
Interesting. So it's not just about weight. There are anatomical factors too.
Definitely. And there are also non-physical risk factors.
Like what?
Age is a big one. As we get older, our muscle tone decreases everywhere.
Including in the throat.
Right, which makes airway collapse more likely.
Okay, and lifestyle factors like smoking or drinking alcohol before bed.
Those can definitely play a role.
And certain medications.
Right, sedatives.
Okay, so if someone suspects they have OSA, what should they do?
First step, talk to their doctor.
Of course.
The doctor will ask about their symptoms, medical history, do a physical exam. They'll likely recommend a sleep study called a polysomnography.
Polysomnography, that sounds intense.
It's not as bad as it sounds. Basically, the patient spends the night in a sleep lab hooked up to sensors.
Sensors that monitor what?
Brain activity, eye movements, heart rate, breathing patterns, blood oxygen levels.
Oh, that's a lot of monitoring.
It gives us a really good picture of what's happening during sleep.
And then the results help determine the severity of the OSA.
Right, which is crucial for guiding treatment decisions.
Okay, so let's talk treatment. What's the go-to approach for OSA?
It depends on the individual and the severity of their OSA.
Okay.
But usually lifestyle modifications are the first line of defense.
So things like losing weight, quitting smoking, cutting back on alcohol.
Exactly. Those simple changes can make a big difference.
What about sleeping position?
Sleeping on your side instead of your back can also help.
How so?
It prevents the tongue from falling back and blocking the airway.
Makes sense. So what if lifestyle changes aren't enough?
Then we might consider other options like CPAP.
CPAP, continuous positive airway pressure.
That's the one.
I've seen those machines. They look a little intimidating.
I can see why some people might feel that way, but they're incredibly effective.
How do they work?
You wear a mask over your nose or nose and mouth while you sleep,
Okay.
and it delivers a continuous stream of air that keeps the airway open.
So it's like a splint for your airway.
Exactly. It can significantly reduce or even eliminate those apnea events.
And that improves sleep quality and reduces daytime sleepiness.
Right.
But I've heard that some people find it hard to wear a mask all night.
Adherence to CPAP therapy can be a challenge for sure.
Yeah, some people find the mask uncomfortable or claustrophobic.
Right. And it can be noisy.
So are there any alternatives to CPAP?
For milder cases or for people who can't tolerate CPAP, there are oral appliances.
Oral appliances, what are those?
They're custom-fitted devices, kind of like mouth guards,
Okay,
that reposition the jaw and tongue to keep the airway open.
interesting. And what about surgery? Is that ever an option?
Surgery is usually a last resort for OSA.
Okay.
When other treatments haven't worked or there's a clear anatomical issue.
So it's not something we jump to right away.
Definitely not. There are different types of surgical procedures.
Some remove excess tissue in the throat,
Others reposition the jaw.
and the recovery from those surgeries.
It can be tough.
So it's important to weigh the risks and benefits carefully.
Absolutely.
Okay, so it sounds like managing OSA is often a multifaceted approach.
It often involves a combination of lifestyle changes, medical devices, and sometimes surgery
And it's important to work closely with the patient.
to find the best approach for their individual needs.
All right, let's move on to another serious condition, shock.
Shock. This is where things get real.
Okay, we're ready.
We're talking about a condition where the body's not getting enough blood flow.
So the organs aren't getting enough oxygen.
Exactly. And that's a big problem.
What causes this lack of blood flow?
There are four main types of shock: distributive, hypovolemic, cardiogenic, and obstructive.
Okay, let's break those down.
All right, so distributive shock is like a sudden widening of your blood vessels,
Okay.
which causes a drop in blood pressure.
Even if your heart is pumping fine.
Exactly.
So two common culprits are septic shock and anaphylactic shock.
Septic shock from severe infection.
And anaphylactic shock from a severe allergic reaction.
You got it.
Okay, so that's distributive shock. What about hypovolemic shock?
Hypovolemic shock is when you lose a lot of blood or fluids.
Like from bleeding or dehydration.
Or burns, exactly.
Less volume means less pressure.
And that's a problem for delivering oxygen.
Okay, what about cardiogenic shock?
Cardiogenic shock is all about the heart.
What's happening with the heart?
It's not pumping enough blood to meet the body's needs.
So it's a weak pump.
Right.
And this can be caused by things like...
Heart attack, heart failure, problems with the heart valves.
Okay, and finally we have obstructive shock,
Obstructive shock is when there's a blockage somewhere in the circulatory system,
preventing blood from flowing properly.
like a pulmonary embolism or cardiac tamponade.
So what are some red flags for shock?
You'll see things like a rapid heartbeat, a weak pulse, rapid breathing confusion,
Wow, so the body's really freaking out.
and you might also see cold, clammy skin and decreased urine output.
So what do we do if we suspect someone is in shock?
Call for help immediately.
Okay, and while we're waiting for help,
Lay the person down, elevate their legs, keep them warm, loosen any tight clothing, and if they're bleeding, apply pressure.
so basically buy them some time and support their circulation.
Exactly, and once help arrives, they'll focus on addressing the cause of the shock.
So how do we treat shock in a hospital setting?
We address the cause and support the circulatory system.
You mean example?
If someone is in hypovolemic shock from bleeding, we need to stop the bleeding and replace the lost blood volume.
Okay, and if it's cardiogenic shock?
We might use medications to improve heart function or procedures to open blocked arteries.
And to support the circulatory system?
We use oxygen therapy, IV fluids, medications to boost blood pressure, and sometimes even a ventilator.
So managing shock requires a rapid response from a whole team.
Absolutely.
Okay, we've covered a lot today. Atelectasis, OSA shock.
All important topics for the MCCQE.
And they all highlight the importance of a team approach to patient care
And lifelong learning.
and patient education.
So as future physicians remember, you have the potential to make a real difference.
Be curious.
Yeah.
Be empathetic, and never stop learning.
You got this.
Okay, so we've talked about conditions that impact breathing and oxygen levels. So let's zoom in on a specific scenario, the postoperative period.
Post-op care. Yeah, it's a critical time for patients. They're recovering from surgery, and we have to be on the lookout for complications.
Exactly. And one of those complications is atelectasis.
Atelectasis, right. We already talked about it in detail, but it's worth revisiting in the context of surgery.
So why is atelectasis so common after surgery?
Well, remember how general anesthesia can affect lung function?
Yeah, it can make those alveoli more likely to collapse.
Exactly. And then you add in pain medications, which can suppress breathing and coughing.
Right, and then there's immobility after surgery, which also restricts lung expansion.
So it's like a triple whammy for the lungs.
It sounds like it. So how can we prevent atelectasis after surgery?
Early mobilization is key. Getting patients up and moving as soon as possible helps expand those alveoli and gets things flowing again.
Makes sense. And we should also encourage deep breathing exercises and using that incentive spirometer.
Absolutely, that game for your lungs.
I love that. But what about pain management? How do we balance the need for pain relief with the risk of suppressing breathing?
It's a balancing act for sure. We aim for multimodal pain management.
Using a combination of different pain relievers.
Right, to minimize the need for opioids, which are the most likely to cause breathing problems.
So we choose the right medications and adjust the doses carefully.
Exactly, and we monitor our patients closely for any signs of respiratory distress.
Okay, what if a patient does develop atelectasis after surgery? How do we manage it?
The approach is similar to what we discussed earlier: deep breathing, coughing, early mobilization.
Those are always the first steps.
Right, and if those aren't enough, we might consider chest physiotherapy or suctioning to clear the airways.
And if the atelectasis is severe,
Then we might need to provide supplemental oxygen or even use non-invasive ventilation to help them breathe.
so there's a whole range of options depending on the severity.
Exactly.
It seems like managing postoperative atelectasis requires a personalized approach and attention to detail.
Absolutely. It's about careful monitoring, early intervention, and tailoring the treatment to each patient.
And communication among the healthcare team is key.
For sure, nurses play a vital role in monitoring patients and providing respiratory care. Respiratory therapists bring their expertise in airway clearance, and pharmacists help optimize pain management and medications. It's a true team effort.
Well, I think we've covered a lot of ground today. We've discussed atelectasis, OSA, and shock. We've talked about their causes, treatments, and the importance of a collaborative approach to patient care.
And we've highlighted the need for lifelong learning and staying up to date with the latest research.
And empowering our patients through education.
Absolutely. As future physicians, you have the power to make a real difference in people's lives. Be curious, be empathetic, and never stop learning.
And remember, resources like Stat Pearls are always there to help you along the way.
Thanks for joining us on this deep dive. We hope it was helpful as you prepare for the MCCQE.
And until next time, keep learning and keep striving to be the best doctors you can be.